Alright guys, we are going to take everything that we just learned, put it together, as well as we're going to add the introduction of the supraglottic airways, so our king airway and our LMAs. We will talk about how they are measured real quick. Our king airways for our adults are measured off of height, size 3, 4, and 5. Size 3 is for an adult that's 4 to 5 feet tall. Size 4 is 5 to 6 feet tall, and size 5 is 6 feet plus. Our LMAs are weight-based. It'll tell you on the LMA what weight that LMA is for, as well as both of the adjuncts will tell you how much air that you're going to use to inflate the balloons on those adjuncts. So starting with the progressive airway, we're going to get dispatched to somebody who's complaining of shortness of breath and some mild dizziness. So we're going to arrive on scene with our PPE on. We'll introduce ourselves. Hello, sir. My name's Andrew. What seems to be the problem? They're going to reiterate that they're having difficulty breathing and that they're a little bit dizzy. While they're talking, I'm going to be assessing their skin color, their level of consciousness again. I'll assess their respiratory rate, depth, and effort. We'll go ahead and we'll get a SpO2 or a pulse ox that goes right on the finger. We're also going to go ahead and assess those lung sounds one more time. So have them take a breath in, again using the ladder technique. So we're going to listen here, go across the rung, listen, go down, listen, and then back across the rung. We're doing that so we're comparing bilateral upper to upper, lower to lower. I don't want to compare the entire lung to the entire other lung because I may forget what one of the lobes sounded like. You will be given a set of vital signs at this point. The vital signs are not specific to where if I was to tell you the exact numbers that are on the sheet, or if I was to alter those numbers a little bit. But it is going to be indicative, telling you that the patient is struggling to breathe. After assessing all of that, we're going to determine that our patient does in fact need oxygen, so we're going to set up our oxygen tank again. So we're going to crack our valve and blow out any debris, make sure that our O-ring is intact and in place, line up our pins, attach our regulator, go ahead and open this up 2 full turns. We're going to start off with our nasal cannula again utilizing the one that has end-tidal CO2 on it. I'm going to go ahead and turn this on, and I'm going to go ahead and start at 4, just based on the imaginary vital signs that I have in my head at this time. So we'll go ahead and attach our nasal cannula to our regulator. Again, ideally this would go in front of the patient's face, but since he does not have any ears, we're going to go behind his head, insert it into his nostrils, tighten down, and once again we would go ahead and hook up our end-tidal CO2. At this point, we're going to reassess our patient. How are you feeling? He's going to tell us that he's still struggling to breathe. We'll reassess our SpO2. Notice that our oxygen saturation is starting to go down, even being on oxygen. We're going to re-listen to our patient's lung sounds using the same technique again. So upper to upper, lower to lower. We're going to assess our patient's pulse, respiration rate, depth, and effort. Determine that since he is getting worse, we're going to need to transition to a non-rebreather. So we're going to take our non-rebreather, or NRB, disconnect our oxygen, turn it up to 15 liters a minute. I'm going to attach my non-rebreather to oxygen, inflate my reservoir bag again. I'm going to leave the nasal cannula on at this time because it does have that end-tidal CO2 on there. So it's another monitoring device that I can use. So we'll go ahead and place this over the patient's head, tighten that down again, instruct them to take nice, big, deep breaths. Then we're going to reassess our patient. So SpO2, we'll assess our end-tidal CO2, respiration rate, depth, and effort, our level of consciousness, We'll listen to our lung sounds again, upper to upper, lower to lower. At this point, we're going to realize that our patient is not as coherent as what he was, so his mentation is starting to go down, his respirations are starting to become ineffective, so we're going to go ahead and lay our patient supine or flat on his back. We're going to grab our BVM. At this point, I'm going to go ahead and attach my inline end-tidal CO2 to my BVM. I'm not going to hook it up to the monitor just yet. We're going to go ahead and take this off, give 2 quick rescue breaths, again using the CE technique. I'm going to go ahead and disconnect the nasal cannula end-tidal from the monitor and connecting my inline to the monitor. I'm also going to go ahead and disconnect my non-rebreather and connect my BVM to oxygen and turn that up to 15 to 25 liters a minute. Go ahead and give a couple more rescue breaths. At this point, I've got 30 seconds. I'm going to go ahead and take my NPA, again measuring from the nair or the nostril to the tip of the ear. We're going to lube it up. Bevel, which is the flat pointy part, is going to go towards the septum. I'm going to go ahead and check gag reflex. Make sure that it's not there. And on this guy at this point it is, but the NPA is not going to affect gag reflex, so we'll go ahead and drop that in. Come back to my BVM, CE technique, and we're going to bag for 30 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. 1, 1,000, 2, 1,000. At this point, we are looking for equal and bilateral chest rise. We're hoping to see the skin starting to pink up. So we're going to reassess our patient at this point, reassess level of consciousness. He's going to be completely unconscious. We'll check a gag reflex. The gag reflex is absent. We're going to check our pulse. We'll check a respiration rate, depth, and effort. He's not breathing on his own anymore. Pulse is still intact. Oxygen saturation is still going down. End-tidal is not improving. So at this point, I'm going to give 2 more rescue breaths real quick. I'm going to measure out my OPA, again, corner of the mouth to the tip of the jaw, to the angle of the jaw, right there at the very back. I'm going to go ahead and use the 90-degree technique, so coming in from the side, do a tongue jaw thrust, twist it, place it down, and come back, and I'll continue breathing. I'm going to pass this off to my partner at this time, who would continue to breathe for me 1 breath every 5 to 6 seconds for a rate of 10 to 12 a minute. I'm going to start with the king. So first thing that I want to do is I'm going to pull the king. Ideally the king is still in the packaging, so we're going to use this packaging as just an example. We've determined that my patient is 5 foot 8 inches, so we're going to use a number 4. So I'm going to apply 60 to 80 milliliters of air using our syringe. I'm going to connect my syringe, inflate my air. Through the packaging, I'm going to test my proximal and distal balloons to make sure that they are holding air. They are. I'm going to go ahead and withdraw my air from the device. I'm going to place a little bit of lubrication on the back of my hand. Makes it easier for me. I'm going to prep my device. While my partner is still bagging, once again, I'm just going to reconfirm that there is no gag reflex. On the count of 3, I'm going to have my partner stop bagging. Again, I do only have 30 seconds to place this device. I'm going to lube up the distal tip. And on the count of 3, 1, 2, 3, my partner stops bagging. I'm going to pull out the OPA. I'm going to do a tongue jaw thrust. So lifting the tongue, I'm going to insert my king airway as far as it'll go until I meet resistance. I'm going to inflate my device with air, disconnect my mask from my BVM, connect my BVM to it, and I'm going to start to bag. And with the king, I'm going to gently pull out until I get chest rise. Once I get chest rise, I'm going to have my partner take over bagging for me. I'm going to confirm placement by looking for any misting. I'm going to confirm end-tidal CO2 is improving, SpO2 is improving, skin color starting to pink up. I'm going to initially listen over the epigastric, which is right underneath the xiphoid process, so right there where your ribs come together at the bottom of your sternum. I do not want to hear any sounds there. Then I'm going to confirm my lung sounds, upper to upper, lower to lower. At this point, my partner is still bagging, so I'm going to get my tape. I'm going to tape from the corner of the jaw around my device to the corner of the jaw. I would call for ALS and I would begin transporting at this time. Okay, so while my partner is still bagging, I have decided that I'm going to place an LMA. For the sake of this patient, we're going to say that this patient weighs roughly, we'll call it 190 pounds. So he is in between the 70 and 100 kilograms for the size 5. So we're going to open up our packaging. We'll look on our size 5. It tells us 70 to 100 kilograms, a maximum of 45 millimeters of air. So we're going to take out our balloon, fill this up to 45, inflate. I'm going to disconnect my syringe. I'm going to fill my balloons to make sure that they're holding air and not leaking. I'll deflate my air. I'll take this out of the bag. I'm going to lube up the back side of the distal tip. Again, I will only have 30 seconds to place this once I ask my partner to stop bagging. So on the count of 3, 1, 2, 3, he's going to stop bagging. I'm going to remove my OPA using a tongue jaw thrust. We're going to seat our LMA as far as it'll go until I meet resistance. We're going to inflate the cuffs, remove the syringe. We're going to attach our BVM, and we're going to start bagging. Okay. I do see that I have equal and bilateral chest rise. We're going to bag 1 breath every 5 to 6 seconds. When my partner is bagging, I'm going to confirm that I do not have any epigastric sounds. Then I'm going to listen to upper, upper, lower, and lower. I'm going to confirm that my end-tidal is improving, my SpO2 is improving, the patient's skin color is starting to pink up a little bit so he's not as cyanotic. And then I'm going to secure my device. So again, corner of the jaw. We'll go around our device to the corner of the jaw. We're going to request our ALS intercept. We're going to begin transporting, and that is the end of our progressive airway.